At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. I'm Donna Cryer, founder and CEO of the Global Liver Institute, and I am so excited to be launching this conversation, this series in celebration of Donate Life Month. As any of you who've been listening and watching for a while, you know that at 28 years and counting post-liver transplant, every month is Donate Life Month for me. But it is a very special opportunity we have today to talk about the role of a transplant pharmacist, a unsung hero on the team. And so with me, I have Dr. David Quan, who is a board certified transplant pharmacist, more on what that is to come, and a pharmacy supervisor in solid organ transplantation and a clinical professor at UCSF Medical Center. Welcome, Dr. Quan.
Thank you, Don. It's great to be here.
So how did you get interested in pharmacy? Were you the star of the chemistry team? Tell us a little bit about you growing up.
So it's interesting that, it kind of goes back, kind of a long story, but in short, I got interested in pharmacy actually back in high school. I really loved chemistry, kind of loved medicine, and kind of felt that pharmacy is really kind of a good combination of the two. And then I actually got a job as actually a delivery person at a local pharmacy. And really there I saw the pharmacist kind of interacting with the patients, and really he got to know the patients really well as people. And that I thought was actually really fascinating. That, and also, again, got to work with all the medications, and he did a lot of compounding, so it's literally kind of making some of the medications from scratch. I also kind of worked in a hospital pharmacy, so saw a little bit of a different aspect of things in the sense of these are now obviously very sick people, and how we actually had made medications in a different way if we need to give the medications to them kind of by vein. So with that, then went to kind of pharmacy school. I did a residency after that, and then kind of was interested in critical care, mainly because I think I am an inpatient person, so I like to see things kind of rapidly change. And in critical care or intensive care unit pharmacists, we work with obviously very sick people, and the medications that we use, I kind of like to watch it have an effect on the patient. And then getting into transplant, there was actually a position that opened up, and my boss at the time asked me to kind of move into this position. And back then there wasn't really any kind of like formal training for a transplant pharmacist. So I had the opportunity to kind of shadow a colleague at a different center and kind of learned a little bit about what they did, and then basically kind of learned everything on the job here at UCSF.
That's amazing. I remember being first discharged after my transplant with like a fishing tackle box of 17 different medications. And so to me, transplant pharmacy must be like the Super Bowl of pharmacy. I can't imagine anything more complex. And so, this idea of board certification in transplant pharmacy is a new thing. Tell us about that and what it really requires. So often the pharmacist in many cases is really behind the scenes, but in transplantation, I got to meet one, and then they're at the bedside, and they're so important because our lives depend on being able to use all of these medications, in the right way, and report back any changes. And so tell us what the board certification asks and what makes transplant pharmacy, so cool.
So the board certification in transplant, and I'm just going to give the abbreviation of BCTXP, is a relatively new certification. So the certification in pharmacies actually goes back to, I think, like the 70s and 80s. So it goes back quite a ways. But at least for transplant, it's really just in the past few years. And really, it was kind of a group of people that kind of came together and says, we really want to make sure that in certain specialty areas, like the ones that in existence, like cardiology, infectious diseases, critical care, oncology, they want to make sure that there's a group of people that have kind of specialized training and experience to make sure that, they can kind of practice at an advanced level. So the concept of the board certification for transplant actually kind of started probably about 5 years ago with a petition to make sure that we have enough people that would fit within this field, and then they developed the examination process, and it's a pretty rigorous examination. There's also some eligibility criteria in the sense that you need to practice for a certain period of time and have some additional training before you can even qualify to sit for the exam. And then you take the exam, which is quite a few hours, and it's a pretty long exam and pretty comprehensive, because it actually goes across all of the aspects of transplant. So from before transplant, kind of during the transplant, and then as well as after the transplant, and all the medication-related aspects of that. And basically what it's trying to do is just making sure that really the pharmacists that have the certification really kind of have some minimum level to be able to kind of practice at this kind of advanced levels, kind of I think the easiest way to think about that. Right now, I think the last numbers that I saw, there's about 250 people that have the certification. And then it's, again, I think in its second year right now of the process, and it's been kind of consistently growing with each time. So exciting.
I'm very grateful for it. And having served on UNOS's Membership and Professional Standards Committee, I really, applaud the coming together of, you and your colleagues to really want to elevate and make sure that there were high standards and criteria inside a transplant center, which is, such a precious point of care and time. So how do you start having the conversation with patients about what they can expect, life, with a transplant to be like?
So here at UCSF, we actually get to really literally see the patient across that continuum of the transplant journey. So I'm going to kind of refer to it as three phases: the pre-transplant phase, the transplant, and then the post-transplant phase. So we have pharmacists in the pre-transplant setting. So as people that are being evaluated for transplant, we'll take a look at their medication list, get a good history to see what they're on, and then try to think about, are there going to be any issues that if they were to get a transplant, would there be any issues with their medications? Like some medication might interact with things after transplant, and if so, then do we need to come up with a plan before they get transplanted? We also have an opportunity to give them a little bit of education of what to expect. So for them to get an idea that they're going to need lifelong medications, they're going to need some monitoring and things like that. So give them kind of a little bit of a preview of what to expect, and then also answer any questions or concerns that they have. So that's kind of a big part of what we do kind of before they come in to get the transplant. And then when they actually are here and get the transplant, well, obviously when they come into the hospital, get, again, a good medication history. So we know what they were taking before the transplant. And then obviously during the transplant, we're kind of making sure they're on the right set of medications. But the other important thing is they're starting to get ready to go home. We really need to make sure that, number one, we know exactly what medications we want them to be on, but also that they can continue on with it after they go home. The transplant medications are very expensive, so we need to make sure that they have access to the medications. We also need to make sure that they know how to take the medications. You mentioned the tackle box, which we actually used to use. And you said, I think about like 17 medications, and that's a pretty typical number. And trying to keep track of all of that stuff, even as a pharmacist, I think is a lot to do, let alone a patient that doesn't have any specific formal training in pharmacy is a lot to really comprehend. So we get the patient involved and obviously their caregivers and sit down with them to make up medication schedules, go over with them how to take the medicines, when to take it. And then when they're ready to go home, make sure that we finalize that list. They know exactly what to take and when. And then they also have access to that medication when they literally leave the hospital. So it is important because these medications aren't going to do anything if they can't get them.
Absolutely. What are some of the top, questions that patients or families have for you as a transplant pharmacist?
A lot of it is around how to take the medicine. So do I need to take it at this exact time? Do I need to take it with food and things like that? What happens if I forget to take a medicine and things like that? And I think hearing about those things really kind of helps us kind of work with them to kind of come up with a schedule that might work well for their lifestyle. As an example, if let's just say somebody works night shifts or something, to try to come up with a plan of how to do things if they're going to be sleeping during the daytime. When they can get labs. Also, I say to me, the most important thing is consistency, how to take a medicine, do it at the same time in the same way. So kind of help, I think, calm some of the fears that they have. And then walk through some issues like, if they forgot to take the medicine, what should they do? Should they take it as soon as they remember? Or if it's so close to the next dose, to just take it at the next time? What we always say is never to double up on the medicines, So things like that, just to make sure that we have the opportunity to really, again, answer any questions that they have.
The challenges for me were time zones. And as I started to travel extensively to start to, correlate in, in shift things in real time so that my body felt it was consistently. Particularly if I'm on a little prednisone, I'm trying to, aim for as if it was a morning cortisol, and not, just keep me awake all night or something. So I think that is, so helpful. And I often, teach patients about, the sort of, rather than being so anxious about the clock, being like when you get up, as you're brushing your teeth, a little bit around habits and behavioral triggers, because those are things that you're going to do consistently. So you can't forget. You're not going to forget to get up and drink a glass of water and things. So then you can't forget, or as part of your bedtime routine, you're not going to forget to do those things. So then you can never forget to, to take your meds. How have you seen immunosuppressants evolve over time? I mean, Prograf was still called FK506 when I started taking it. So there are some new medication, but in some ways things haven't changed. But what have you seen in terms of evolving in medications?
I guess I'm gonna be dating myself where I can say I've seen a lot of these things kind of evolve over time, like you said, with the tacrolimus, also known as FK506. I think really the overall themes over the course of time is that they've evolved to, I think now we have better medications, in the sense of we have tacrolimus, which is Prograf, and then some newer versions that are like once a day, so it's a little bit easier to take. We also have some developments in some of the newer antibiotics and antiviral medicines from the standpoint of help preventing infections, and that have really kind of been good in the sense of being able to prevent certain infections that we see after transplant much, much better than what we had from before. But kind of like you said, some of the things really haven't changed. We still use the prednisone today. We still use the Prograf today and things like that. But I think we've gotten a little bit smarter on kind of how to use things and in certain situations to kind of tweak things. There's been a couple of other medicines that have come out that totally, completely avoid tacrolimus, something called belatacept, also known as Dulogix, is a medicine that is given by infusion once a month. And might have some benefit in help protecting the kidneys, at least in the kidney transplant patients. So there's been some incremental evolution in the transplant medicines. And then hopefully we'll have a chance later on to talk a little bit about hepatitis C. And I think a lot of the exciting things that have happened in that area, and especially in liver transplantation and other organ transplants too.
Absolutely. But before we get there, I do want to talk about, kidney preservation. I think particularly for long-term liver transplant recipients, many people aren't as aware that sometimes the medications can have a, can wear on your kidneys, to put it in lay terms, have nephrotoxic effects, and so we need to be watching our kidney health. Are there some advances in helping non-kidney transplant recipients stay non-kidney transplant recipients?
Well, I think first of all, it is kind of almost ironic that for like a kidney transplant patient, some of the medicines that we use can affect their kidneys in a good way as well as a bad way. And then in the non-kidney transplant population, so like liver as an example, I think we need to be very mindful that we're always kind of focused on the liver. And we also need to be mindful of the kidney in the sense that, there's a proportion of patients that might end up getting kidney failure and need a kidney transplant as a result of that. And I think over the course of time, again, some of the medicines that have come out have allowed us to use maybe lower doses of the tacrolimus as an example, which tends to be a little bit more toxic to the kidneys to hopefully help kind of minimize the effect on the kidneys. I think the other thing is just, again, making sure patients know not to take other medications that might hurt the kidneys, typically what we call like the non-steroidal anti-inflammatory drugs that we commonly use for minor aches and pains. Those can have some pretty significant effects on the kidneys. But unfortunately, our tried and true tacrolimus medication, while very effective at preventing rejection, does have some significant side effects like affecting the kidneys.
What can patients do if they are, dutifully, trying to avoid NSAIDs, but opioid options are, hard to come by in this regulatory environment. And so I hear from a lot of patients that we feel like we're caught between, like, we really don't have options, and we're just supposed to just don't have pain. Don't have pain because there are no solutions really offered. What can people do?
I think the first thing is to really sit down and talk about it with the healthcare provider. Again, with pharmacist, the nurse practitioner, or the physician, as to what kind of pain that they're experiencing, and to see and I always think of non-drug things that we can do to help with that, ice it, things like that, or just to minimize that. I think if it's some kind of physical pain, definitely think about like physical therapists and occupational therapists. I think those are definitely things to consider. But also, are there other kinds of what I call topical options? So sometimes some local anesthetics. There are sometimes some local versions of a non-steroidal that if you use just a little bit, sometimes that might help. But I think the most important thing is to really have that dialogue with the provider to see what are our options. Obviously, there's sometimes some other non-opioid medications that we can use to help with certain types of like nerve pain and things like that might be very effective. So I think the first thing and probably the best thing that I would recommend is really to start that conversation with a healthcare provider that says, look, I'm experiencing some pain. What are my options, knowing that I can't do these things?
Right.
And then for them to kind of think about some other options. But as always, this sounds weird coming from the pharmacist, I always want to think about non-drugs first before I think about drugs, because sometimes those would be really sometimes the best things to do.
Right. My trainer, I know I work out extensively, and I'm over 29, let's just say. And so, we knows that comes straight home, and it's ice, eat protein, it's Epsom salt bath, and then we'll see what's left. We'll see where we stand from there. But that is a super, super important part of the regimen. And I sort of tease with some folks. I'm like, whatever age you are, that's the percentage of time that you need to spend stretching and foam rolling after your workout. And so I think that's an important part of it. I think that my friends who use TENS devices, and I think having that conversation rather than just feeling sort of hopeless and stuck with nobody sort of paying attention, and not honoring our pain in the same way cancer patient pain or other patients' pain is honored. Just sort of going through life long enough, you're going to have some pain, and so knowing that there are options and a conversation that can be had, I think, is reassuring to people.
Yep.
And so let's talk about hepatitis C, because that certainly has changed transplantation. There are patients who are able to accept hepatitis C positive organs and then be cured. There are patients who no longer need transplants because there's a cure for hepatitis C. And so, tell us how it has changed the landscape for you.
I mean, without a doubt, the management of hepatitis C has really kind of evolved over time. But I mean, imagine this for a moment. Within our lifetime, the hepatitis C virus has been identified. We've been able to bring drugs to market to treat it. And today we have, treatments that are basically 95% effective, one pill a day for, regimens as short as 8 weeks. I mean, how much better can you ask for that? And very few side effects and very kind of transplant drug friendly. But I think it's also kind of a very simplistic view, because we also have to be mindful these are also very expensive treatments. Upwards when they first came out was like $1,000 a tablet, and that caused a lot of stir there. But I think what was really kind of unintended,
except for nobody paid that, and
right.
Nobody explained in the newspapers that nobody paid that.
Right.
And then when competitors came through, really nobody was going to pay that. And then subscription models came out in Louisiana, and so I think that the focus on the value of being able to cure millions of people with an infectious disease, didn't do too well when confronted about sort of dramatic headlines about a price that frankly is less than my IBD medication that I take every month.
But what's interesting though is I think what it did was it started that conversation, and it got people to, to the politicians, and to basically say, look, we need access to this treatment. And I think that was really kind of the neatest thing, that initially, we had issues with barriers to access, and now, with Medicaid and Medicare, and then a lot of insurance companies saying we're following, the national guidelines on that, really, I think, opened the door to really kind of allow people to be really effectively treated. I think it's still, I think to a degree, still some barrier, but I think we're definitely where we are today is much better than where we were, 5-10 years ago, when, we had a lot of trouble getting these medications. But I think what's also interesting is that, before, again, if you had hepatitis C and got a liver transplant, there's a good chance that you're going to get it again. And that was a major barrier and major consideration if they should get a liver transplant. Where we are today is we're actually considering people that have had a transplant. Do we want to use donors that have Hep C positive or Hep C positive donors? And it's a wild idea to think about. We might actually give a donor-derived infection, but with these treatments that are so effective, we can effectively either prevent it or treat it soon after transplant. And I think that, again, has really kind of revolutionized things, and I hope will help increase, I think, the number of donors that are out there, which will then translate to hopefully more transplants that can be done.
Absolutely. Another question that I have that we, is evolving information is COVID vaccination, vaccinations in general for people with transplants. And certainly as COVID persists, people you're trying to understand, how many boosters would be necessary and how to time them out. And so, what are the current recommendations for transplant recipients, either prior to the transplant, and then post transplant?
I think one of the easiest way to kind of think about it is COVID is no different than any other kind of infection. If there's I think if there's an effective vaccine, we should do that, because can be a preventable or something that can at least minimize the seriousness of the infection. So we've kind of included that as literally part of our part of the workup for a liver transplant. I think, as usual, the earlier you can do it, the better, especially if we know that they're going to be getting a transplant. More from the standpoint, it gives the opportunity of the vaccine to kind of kick in, so to speak. But we also realize that, liver transplant can occur very acutely, so they may not have been able to complete their course. And what we typically will say is that usually, if they're kind of somewhere in the middle of that vaccine series, after transplant, we want to wait a little bit of time just to make sure to let kind of some of the anti-rejection medicines effects kind of go down a little bit, to give the booster shots kind of as much of a chance for it to kind of do what we want it to do. So we typically will say wait a couple of months after transplant before completing the series of the vaccines.
Excellent. There were a lot of transplant recipients who participated in vaccine effectiveness studies that gave us a lot of information about, which vaccine and who and how many that influenced. I know you're involved in a lot of research. What types of research questions are you pondering these days, and how can patients participate in
So
research?
one was actually just related to COVID.
Mm-hmm.
Was one is now moving past the vaccines to the treatments.
Mm-hmm.
We have some treatments out there, but one of the treatments out there, the Paxlovid, has some very significant drug interactions with the transplant medicines. So we recently kind of took a look at a series of some lung transplant patients that got the Paxlovid and tried to look at can we adjust their transplant medicines relative to when they got their COVID treatment, and kind of came up with some recommendations. But really the key thing is, like with the vaccines, the treatments that are out there are very effective, but the key thing is that it can have some very significant side effects, so as well as some drug interactions. So you need to be very careful about that. And again, have that conversation with the provider that says, look, I'm a transplant patient. Is this going to be okay to do? So that was one kind of the more recent things that we've kind of looked at. But we've also looked at in some other populations, looking at how we can minimize the use of opiates after certain types of surgery. One of them was in the people who donated a kidney. And we came up with some strategies to where we actually came up with some opportunities to where they actually didn't need very much opiates. So hopefully they have less side effects and just less risk of addiction and all that. So there's some exciting things in that respect. And then on the liver transplant side, we're always looking at various types of infections that we see after transplant, and are there opportunities to try to minimize that or minimize side effects associated with some of the antimicrobial agents that we use.
Are all of these randomized clinical trials, or are they, are you using, queries of your EHR, or, has the way that you've been doing research in transplantation changed?
Obviously there's the large, randomized controlled trials, part of these multi-center trials that we're involved with. A lot of it is also what we call case series, where we see how we use a certain medication, and then we might compare that to what we used to do before, like what we call a historical control. So it's kind of our evolution of how we are learning to use certain types of medications, or how we are approaching certain types of clinical situations. That's kind of the research that I typically do, is what I call kind of clinical research, as opposed to like more the bench research. But again, I have colleagues that do a little bit more on the actual formal clinical trials and things like that. So a lot of it is really, again, everybody has kind of different areas that they have interests and specialties in.
I think, patients are fascinated by the idea of a learning health system, and want to ensure that, everything from every, doctor's visits or interaction with the health system, leads to improved care. And I think most of the day-to-day questions that patients have do fall more into this sort of translational, applied type of research. I know, for example, when I went into have my knees replaced, because I was in the days when we used a lot of prednisone for a long time after transplant. I wanted to know, well, how do transplant, recipients do on total knee replacements, and, and how do we, appropriately pull my immunosuppressants, back a bit to allow me to heal, and then, how do we, sort of re-engage my normal medication regime. And so it was hard for me to sort of get that information to understand how to optimize. So I think the type of work that you're doing really is at the core of the types of questions that patients have. So I'm glad to know that we know about you now. And that there are ways that patients can participate and support research outside of participating in sort of a new drug entity trial. That there are types of research that we can support through surveys, through other means that are helping other patients and advancing the field. So.
Yep. Yeah, there's a lot of transplant centers have, obviously are part of clinical trials, and some of them are these full-on big trials with like new medications. But a lot of it is also, again, just advancing our knowledge and as to how we do things. And sometimes, yeah, a lot of patients will be approached about, oh, yeah, we're conducting this study. Would you like to be a part of it? And I know that at least here at UCSF, we do that with a lot of our patients in various aspects of things, just like even looking at like frailty going into liver transplant and things like that are things that, we've looked at as we, kind of evaluate people for liver transplant.
I think that's huge. And as we understand sort of the changing face of transplantation, where it used to be a lot of autoimmune patients like me, and increasingly it's NASH patients, understand issues like frailty and the nutritional support that I might have needed prior to transplant is very different from what a NASH patient needs. Their medications are different. They're likely to be on diabetes medications and other things. So that's a very different challenge for you. So I would encourage patients to say yes if approached for clinical research at an esteemed institution like yours. Are there other ways that we can help, or other things that you're excited about on this forefront in your work to leave our audience with?
Well, I can probably go on all day. I mean, there's so many different aspects of things. And again, we're looking at it at pre-transplant levels, like looking at their genes to see might they handle their drugs differently? And then if we can get this test going into transplant, when they get the transplant, then we'll have a better idea of how to like dose their medications. Those I think, again, are some really fascinating areas that we are really kind of, again, considering. Obviously, new medications coming out, and then just, again, how we use our existing medications. I think we've learned a lot, but I've also come to a conclusion. I think there's still a lot that we still have to learn about these medications.
I appreciate your leadership in helping us learn how to optimize this great gift, this great miracle of organ donation and transplantation. And so thank you for being part of this conversation today.
Appreciate the opportunity.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.